This conference will now be recorded.
Today's topic is burns. Burns is defined as a wound caused by exogenous agent, which is leading to the coagulative necrosis of the tissue. Different types of burns are thermal burns, chemical burns, electrical burns, cold burns, and radiation-induced burns. Thermal burns can be dry heat or because of moist heat. Dry heat is maybe because of contact burns or flame burns. Moist are because of scalp burns. Smoke and inhalation injuries or also comes under thermal burns. Chemical burns are because of chemicals like acids and alkali. Electrical burns, it is because of high voltage or low voltage. Cold burns are because of frostbite and radiation-induced burns. These are different causes of burns. Thermal burns. Heat changes the molecular structure of the tissue, causing it the denaturation of the proteins. The extent of burns will depend upon the temperature, amount of heat, and duration of contact with the agent. The effects of burns are influenced by the intensity, duration, and type of tissue got injured. Pathophysiology of burns. Once the patient got burned, there will be in that area there will be fluid shifting because the insult area there will be inflammatory reaction. Because of that, there will be accumulation of the chemokines, cytokines, and which leads to vasodilatation, and there will be increased capillary hydrostatic pressure and increased capillary permeability. Because of increase in the capillary permeability will lead to the continuous leak of plasma from intravascular into the interstitial space. This is third space loss of fluid. Where there will be, because of fluid loss, the patient will go into dehydration and there will be associated imbalance of fluids, electrolytes, and acid-base imbalance will also be seen. Because of third spacing, the intravascular volume will be decreased. This is nothing but hemoconcentration. This period will last for 24 to 36 hours. Then comes the fluid remobilization. From the interstitial, the fluid will come into capillaries. The fluid will shift back into the intravascular space. This restores the fluid balance and there will be renal perfusion will also get restored. And there will be increased urine formation and diuresis. And this continues the electrolyte imbalance. Hyponatremia and hypokalemia are because of this hemodilution. Systemic changes. Different systems reacting to that of burns. In case of cardiac, there will be decreased in the urine output. Pulmonary, because in the case of inhalation injuries, there will be damage to the alveolar tissues. And there will be respiratory insufficiency as a secondary process. Because of respiratory insufficiency, patient will go into respiratory failure. And the aggressive fluid toileting and oxygenation is the treatment. Gastrointestinal, there will be, because of this increased metabolism and metabolites, there will be decreased or absent mobility. So the patient requires NG tube. And Curling's ulcer formation is seen in this burn patient. It is because of the mucosal deficiency. In case of head injury, that is Cushing's ulcers. That is because of decreased in the acid output. Here the acid output will be normal. Metabolic. There will be hypermetabolism. Hypermetabolic state is seen in case of burn patient and increased oxygen and calorie requirement into the burn patient and increase in the core body temperature. Immunological. Because of burns, the immunity of the patient will be lost. So loss of protective barrier increase the risk of infection. Once the immunity is lost, there will be high chance of infection, and it is because of loss of humoral and cell-mediated immune response. Body responses to burns: emergent phase, fluid shift phase, hypermetabolic phase, and resolution phase. Emergent phase is a painful response. There will be release of catecholamines, which lead to tachycardia, tachypnea, mild hypertension, and mild anxiety. Fluid shift phase. It takes 18 to 24 hours, begins after this emergent phase, and this peaks up 6 to 8 hours. Damaged cell will initiate the inflammatory response. Shift of fluid from intravascular into extravascular space, which will lead to edema. Hypermetabolic phase. This lasts for few days to few weeks. There will be increase in the body needs for nutrition and its repair itself. Resolution phase. Here the scar formation will take place and general rehabilitation and progression to the normal function. Jackson's theory of dermal wounds. These are different zones in burn. This is zone of coagulation, next is zone of stasis, and next is zone of hyperemia. In case of zone of the agent will come in contact with this zone. This zone is called zone of coagulation, where there will be necrosis and there will be tissue loss. And in case of zone of stasis, the tissue will be either go into necrosis or either it will go into zone of hyperemia. So the treatment which we give based on this zone of stasis. Here, next comes the zone of hyperemia. Here, the blood vessels will be dilated, and this is zone of coagulation is area in the burn nearest the heat source that suffer the most damage, and it is a irreversible tissue damage will take in this place. This is zone of necrosis. This zone of coagulation is irreversible. We cannot change this. The tissue will go into necrosis. Next comes the zone of stasis. The area surrounding the zone of coagulation is characterized by decrease in the blood flow. Here the blood flow will be reduced. Here, in case of zone of stasis, the tissue will either survive or go into necrosis. So we should not give cold, in case of burn patient, we should not use cold water because cold water will causes vasoconstriction, which will further make this tissue in zone of stasis into necrotic phase. And thromboxane is potent vasoconstrictor is also avoided in case of zone of stasis. Zone of hyperemia, peripheral area around the burn that has increased blood flow. Severity is determined by depth of wound and the extent of burn calculated in the total body surface area, location of burns, and patient risk factors. Classification of burns. There are different first degree burns, second degree burns, third degree burns, and fourth degree burns. First degree burns is only localized to the epidermis. In case of second degree, it can be superficial second degree or deep. In superficial second degree, along with epidermis, superficial papillary dermis is also involved. In case of deep second degree burns, along with epidermis, there will be reticular dermis. Reticular dermis is also involved. In case of third degree burns, there will be full thickness involvement of epidermis, dermis into subcutaneous fat. In case of fourth degree burns, the injury through the skin, subcutaneous fat to underlying muscles or bones are involved. Superficial burns are first degree burns. Generally, the superficial burns are there will be red. The skin will appear red. Pain is present and involves the epidermis. There will be blanch on touch. Have intact epidermal barrier. and does not result in scarring in case of superficial burns. Example, sunburns, minor scald from kitchen accidents, and we can treat this with soothing agents. In case of partial thickness of second degree burns, there will be involvement of epidermis and papillary dermis. And there will be spares the hair follicles and sweat glands. Here there will be erythema, blanched to touch is present. There will be blisters in this phase, and it is very painful. It heals either with minimal scar or no scar. Spontaneous reepithelialization will take place in 7 to 14 days in this partial thickness burns. Examples of scald injuries from overheated water tub or flash flame burns comes under this partial thickness burn. Deep second degree burns, the injury of the deeper layers like reticular till reticular dermis it got involved. In case of first degree and superficial second degree, the burned area will appear erythematous. But in case of deep second degree burns, it appears pale and malted. And in this first two, there will be blanch on touch is present. Here, there will be blanch on touch is absent. Capillary return in this area will be sluggish or absent. It is less painful when the superficial and second degree, superficial second degree burns. These are very painful and remains. They have pinprick sensation. It heals. The epithelialization will take from 14 to 35 days. There will be it heals with scarring, and there is such high chance of contracture formation will be also there. So they require excision and skin grafting. Full thickness third degree burns. These burns appear dry, leathery. A scar will be formed in case of full thickness third degree burns, which is all. And there will be loss of sensation. Pinprick sensation will be there in deep second degree burns. But in case of third degree, there will be loss of sensation. Scar formation will be there. All dermal layers will be involved. And reepithelialization will start from the wound edges. Here we'll excise the wound and we can go for skin grafting. Fourth degree burns, it involves the structures beneath the skin like muscle, bones. Assessment of burns. We can assess by rule of 9 or rule of palm. Can anyone tell about rule of 9? Rule of 9 is best used in case of large surface area. Expanded tool to measure the extent of burns. Rule of palm is best used for burns less than 10% of body surface area. Rule of 9, head and neck 1%, front 1, front 18, back 18, each lower limb 18, upper limb 9, and perineal area 1%. In case of children, rule of 9 is not used. It can be used, but it is not accurate. Palm area of one palm, which palm will take is patient's palm, will measure in one paper, will cut that paper and will measure the surface area. This is used in case of flash burns or the burns in different areas. Then we can use 1% or one palm is equal to 1% of total body surface area. Management of burn patient. In case of pre-hospital care, we should secure the safety of the patient. We should take away the patient from that incident site and stop the burning process by rolling the patient in a bed sheet or by using tap water. Check the other injuries like airway, breathing, circulation, followed by rapid secondary survey is also done. Inhalation, if you suspect any inhalation injury, when there is any sputum consists of smoke particles or singed hair is there in the nares, then we can think of when the patient had a history of burns in a closed room, then we can think of inhalation injury and we should start 100% oxygen. Room temperature water should be used to decrease the depth of wound. Hospital care. After coming, we should see for airway, breathing, circulation, any disability like neurological status of the patient, exposure with environment control, and fluid resuscitation. Secure airway and proper ventilation. When you are suspecting inhalation injury, when there is soot around the mouth or nares, grayish or blackish sputum, singed nasal hair, burns to the lower face and neck, stridor, hoarseness, dyspnea, persistent hypoxia, full thickness burns or circumferential burns of chest wall. In these conditions, we should think of inhalation injuries and we should secure the airway. Why we should secure the airway in case of inhalation injuries? Because there will be laryngeal edema. If we won't secure the airway, there will be later we cannot intubate that patient and we have to do cricothyroidectomy. Supplementation of 100% oxygen. Nasal cannula can be used in majority of the patient. 100% oxygen is used in respiratory burns inhalation and carbon monoxide poisoning. Circulation. Maintain IV lines with wide bore cannula peripherally. Two wide cannulas can be used. Preferably upper limb is used. Brachial, we use upper limbs. Even in the burn area, we can use. If upper limb is not possible, then go for central line. Sclerotomy of the limbs is circulatory compromise in case of circumferential burns. In case of when the wound is eschar formation is circular, even if you intubate to the patient cannot breathe. So at that time we have to do eschorotomy. So we will give incisions and relieve the pressure so patient can breathe adequately. Fluid for resuscitation. In children with burns over 10% total body surface, an adult with burns with 15% of total body surface, consider the need of intravascular fluid resuscitation. If oral fluids are used, salt must be added. Fluid needed must be calculated by standard formulas. The key is to if we want to check the patient whether the patient is adequately resuscitated or not. The main thing we'll see is urine output. Parkland formula. This is most commonly used formula in burns. Generally, this is a crystalloid based formula. Volume is equal to 1% of total body area burned into weight in kgs into 4 ml per kg. In this, the fluid we have to give is calculated for 24 hours. This 24 hours is from the start of the incident, not when the patient comes into the hospital. It is from the incident itself. Half of this volume should be given in first 8 hours and second half should be given in subsequent 16 hours. And the second day, we'll give half of the first day fluids, means half of this. The preferable crystalloid is ringer lactate. We can use hypertonic saline, human albumin solution, normal saline. Colloids we use are plasma, hetastat, and dextrans. The commonest colloid-based formula is Moore and Berkeley formula, which is 0.5 into percentage of total body surface burnt into weight is equal to 1 portion. This 1 portion we give 4 portions or 6 portions or 12 portions in 12 hours respectively. 1 portion is given in each period. The assessment of adequacy of fluid resuscitation can be done by urine output. The urine osmolarity is most accurate formula. but we won't see urine osmolarity. Will mostly see the urine output. Urine output should be maintained 0.5 to 1 ml per kg per hour. Central venous pressure should be maintained 5 to 10 centimeter per water. Urine output more than 2 ml per kg per hour is the sign of overhydration. We should not overhydrate the patient. We should adequately hydrate this patient. So we should stop the fluids once the patient is got overhydrated. Escherotomy, circumferential deep second and third degree burns of extremities and peripheral circulation of limb can be compromised. If there is eschar formation at the limbs, there will be edema behind the eschars. So in the compartments, the pressure, there will be anterior compartment, posterior compartment, medial lateral compartments in the limbs. So if there is increase in the pressure, the vessels going through that will get blocked because of the increase in the pressure. So the circulation will be compromised in these patients. Generally, patient will have numbness, tingling, increased pain in the digits. Arterial flow should be checked using Doppler. We should examine capillary refill time and tissue perfusion. And the tourniquet effect of this injury is easily treated by incising the whole length of the full thickness burns. Escherotomy incise longitudinally along the medial and lateral surfaces. Completely relieve the impediment to the blood flow. Debridement. It can be auto debridement or tangential excision or staged primary debridement, or for deep circumferential burns, escherotomy will go. Analgesics should be given. And in case of small acute small superficial burns, only oral analgesics and topical cooling will be enough. In case of large burns, the intravenous opioids should be given, and continue analgesia is required, and beginning with infusion and continuing with oral tablets such as slow release morphines. Nutrition. Burn patient needs extra feeding because there will be hypermetabolic state. So there will be catabolism of protein and hypermetabolic response, and there will be decreased lean body mass. So the nasogastric tube should be used in all patients with burns over 20 body surface area. 25 kilocalories per kg per day plus 40%, 40 kilocalories percent of total body surface per day should be added in these patients. Tetanus prophylaxis. If the patient is already taken the tetanus within the 5 years, then we can give tetanus toxoid 0.5 ml intramuscular. If with the booster dose when the booster dose was more than 5 years before the injury. If immunization status of the patient is not known, then we can give immunoglobulins 250 to 500 units IM plus tetanus toxoid in the opposite side. Monitoring and control of infection. Burn patients are generally immunocompromised, so they are suspected to infection for any route. Sterile precautions must be vigorous. Swabs should be taken regularly and sent, and a rise in the blood count and thrombocytosis and increased catabolism are the warning of infection. Topical treatment in case of deep burns, we can use 1% silver sulfadiazine or 0.5% silver nitrate, mefenamide acetate cream, bacitracin or polymyxin neomycin can also, these are different topical agents which are used in case of burns. Most commonly used is 1% silver sulfadiazine. 0.5% silver nitrate can be used, but there will be blackening of the furniture if we use the silver nitrate. Mefenamide acetate cream is mostly used in US. It will called as a metabolic acidosis. And this 1% silver sulfadiazine is a broad spectrum antibiotic. and it acts against MRSA and as well as Pseudomonas, which is very most common infection in case of burns. Full thickness and deep dermal burns need antibacterial dressing to delay the colonization. Superficial will heal and need a simple dressing. Surgical treatment of deep burns. Early debridement and we can go either for early debridement and grafting, which is effective in case of deep partial and full thickness burns. In case of deep dermal burns, need tangential shaving and split skin grafting. All but the smallest full thickness burns need surgery. Should be ready for significant blood loss, so blood should be arranged. Topical adrenaline can be given, so the burns bleeding will be reduced. All burn tissue need to be excised. Surgical treatment of deep burns. Proper dressing should be done. Dressings can be either closed dressing or open dressing. Open dressings are used in case of face and neck injuries and superficial burns. Postoperative management requires careful evaluation of fluid balance and level of hemoglobin. Physiotherapy and splints are important in maintaining the range of movement and reduce the joint contractures. How much you treat post-op, we should give the patient good physiotherapy and splints. So the movements, the joint should be maintained properly. Delayed reconstruction of burns can also be done. So either we can go for excision and skin grafting, or we can delay the once the patient got stabilized. After that, we can delay and then we can repair the burns. Eyelids, we should treat it before the patient get develop the exposure keratitis. So eye care should be given, proper eye care. The transposition flaps and jet plastics with or without tissue expansions are also useful. Full thickness grafts and free flaps may be needed for large and difficult areas. Hypertrophy is treated with pressure garments and silicone patch. With around 6 to 8 months, we have to give this pressure garments and silicone patches. Pharmacological treatment for itching is very important. Wound closure, granulation. Either we can, once the wound got granulated, we can go for split skin grafting, or if the area is very large, then we can mesh this split skin graft and we can use in that area. Face and ear, because split skin graft is like cosmetically it is not good when compared to full thickness graft. So face and ear cosmesis is very important. So we have to go for full thickness graft or flap is required. In case of electrical burns, it can be either low tension burn or a high tension injury. In case of low tension injury, the volts is less than 1000 volts. In case of high tension injury, it will be more than 1000 volts. Greatest heat occurs at the point of resistance. Once the current will flow, in case of high tension injury, there will be tetany. So the patient cannot get away from that electrical instruments. So the patient will go into tetany, this high tension injuries. And once the current passes into our body, there will be increased resistance and there will be entry wound and exit wound, as you study in forensic about this electrical burns. Dry skin, there will be greater resistance than wet skin, have less resistance. Longer the contact, greater is the potential of injury. And smaller the point of contact, the more concentrated energy and the greater the injury. So longer is also there will be greater injury and the point of contact is smaller, then the injury will be more. Insert results serious vascular and there will be serious vascular and nerve injuries. Immobilization of muscles are required. Flash burns, either the patient will have cataract, progressive demyelinated neurological loss is seen. We should, once the patient comes, we should assess the patient. We should look for entry wound and exit wound, remove the clothing, jewelry, and leather items, treat any visible injuries. And ECG should be taken because in this path the heart will get involved and there will be erythemas in the ECG. So we should look for any bradycardia, tachycardia, ventricular fibrillation, or asystoles. If there is, then we should treat the patient. Treat the cardiac and respiratory arrest with aggressive airway management, ventilation, and circulatory management. Consider fluid bolus for serious burns. 20 ml per kg should be given, and sodium bicarbonate is also added. Mannitol is added because of the muscle got damaged, which releases the myoglobin into the circulations. This myoglobin in the renal, it will go and accumulate in the renal tubules, which causes renal failure. So to avoid this, we have to adequately hydrate the patient and we should give mannitol to prevent the renal injury. Thank you. Any doubts?